just to second that, I mean, my day job is I'm an NHS eye surgeon, and I do mainly cataracts, and I certainly know of at least 2 people where I've taken their cataracts out because they come in with a cataract and visual symptoms, and we take their cataract out, and their visual symptoms are exactly the same. And they think, oh, maybe there's something else going on. Eventually, we then focus on their eye, you know, they've got macular degeneration, they've got diabetes, whatever, and then after a while the penny drops. But it's actually the processing of the information, not the information itself. So, my name's Paul Ursell. I'm just going to check something. Okay, so my day job is an eye surgeon, and I chair this group, but I don't do the work. The eye guys do all the work, and I just happily sit there. But what we decided to do was create some standards about people coming to the eye department. So you've got dementia, you've got sight loss, and you go back to my department. How are we looking after you? So, as we discussed, I'm really sorry about the slide, but I don't know the size of the screen with this big. But hopefully you can read this now, or you can come out on our website after, so you will be able to download them afterwards. But dementia is basically losing your cognitive abilities, and it's an umbrella term for a variety of different causes. And this means that you can't perform your activities of daily living, really, because your memory is impaired, affecting your communication, your ability to reason, and your ability to understand. It's not just your ability to remember, it's a variety of other diagnoses or symptoms. And as we touched on earlier, everyone says dementia is Alzheimer's. Well, Alzheimer's is like heart failure is caused by smoking. Well, you know, heart failure is caused by other things as well. So Alzheimer's is a cause of dementia, but there are other things as well. So vascular is another common cause. Basically, we just have lots of these small infarcts in the brain causing the form of dementia. And then there's post-cortical atrophy, Lewy body disease, and other rare causes. But CJD as well. Remember all that with the new progress? Can we get these lights down a little bit? We'll try that. And the thing is that it's a multifactorial disease. These people are all elderly, and elderly people don't just get one thing, they get loads of other things. And sight loss is one of those. They have vision, hearing impairments, they have mobility issues, everything else. And the sight loss in people with dementia is either caused by something in their eye, so you've got a cataract, as we touched on earlier, or macular degeneration, as we saw in the right study, or another health condition, which is not dementia, or you had a stroke, or you've got a lazy eye from birth, or something else like that, or the dementia itself, as we just heard with the post-cortical atrophy. So there's 3 things causing your sight loss in your dementia, or your sight impairment, your sight loss or sight impairment. So if you just look at the latest figures, we know that there are about 2 million people in the UK over the age of 65 with sight loss. And there are 850,000 people over the age of 65 in the UK with dementia. It's difficult to say exactly, but we reckon there's about 120,000 where that overlaps. And that's in 2013 in the over 65s. So there's quite a lot of people with this, but it's not a huge amount. It's not, we're 65 million people in the UK, so it's a lot, but it's not enormous amounts. Trouble is, we've got available with us the demographic time bomb of the age of population. So this is the Office for National Statistics. This is official UK government data. And this is over 75s, not 65s, but over 75s. And this is now, and in 25 years' time, it's going to go up. So whatever we're dealing with now, the healthcare economics and the pressures on our healthcare services, there's twice as much of it in 25 years. It's as simple as that. So we've got to run to keep still. So if you've got dementia and you've got sight loss, it's not very nice. And it makes life particularly difficult for you. It's an added burden, not only for you, but for your carers. And those of you who aren't carers will know this. And what we want to do is to try, as in all healthcare environments, is to maximise the quality of your life, maintain your independence, and particularly reduce the incidence of falls. It's well known that sight impairment equals falls, and if you fix people's sight, they don't fall so much. They fall over things, they don't see it. And if you have a fall, break your hip, that's bad news. You break your hip twice, you don't get right in hospital. So you don't want to have falls. So we produce these quality standards for people who are this increasing number of people who are going to have dementia coming to the eye. Who here works in eye clinics? We're seeing more and more now over the years of people coming in who have got dementia. And we're following standards or protocols, particularly the NICE guidelines. So there are already NICE guidelines out there for dementia. So those of you who work in the dementia field will be aware of these two. So it's quality standard 1. This is basically about health and social care in direct contact with people in hospital with dementia. And quality standard 30 from NICE, living well with dementia outside hospital in care settings. So those are colossal 200-page documents. I don't expect anybody to go. I certainly had a look at them and read them. Got quite scared and then read the important bits and then read the rest of it. So what we created is about 7 statements of things we would like to happen for people with some dementia sight loss coming to your eye clinic. So the first thing is that the people who are looking after you know what the hell they're talking about. So we need to make sure there's some training for the staff in the department. So that's the fundamental criteria, is making sure the staff, even if you identify the patients, know what they actually the staff know what to do. We didn't say what the training was, but we need to say there should be training. Because if we said what the training was, it gets very complicated. But you need to make sure that the staff have some training. The next thing is that people come in to see us, we need to make sure that there's information for patients and their carers coming in. Now most people who go to an eye clinic usually come in pairs because you're going to do something to their eyes or they're coming with a carer anyway, but virtually everybody with dementia and sight loss is going to come in with a carer. So you know that there's going to be 2 of them, so you have to apply everything to the carer as well as to the patient. So we need to make sure they've got accessible information, and accessible means it's in Braille, it's in large print, it's in Urdu, it's accessible for the people who are coming in. And one of the big problems with this is that if you work with dementia, they have good days and bad days. And that's the problem. They'll come in and you've got them on a bad day for their appointment and we'll have to go to their days. So you've got to be aware of the fluctuating levels of capacity of people who come in. And because you're giving them appropriate information, you're expecting and hoping that people, despite their cognitive impairment, can be involved in the decision-making process about their care. You're caring for them, not their carer or their eye, but them as a person. And that understanding of their fluctuating ability is crucial in thinking, you know what, we need to have another go at this another day. Or today we've got a decision and then they were up for it, and then next time they may change, they may be different because their fluctuating level of cognitive performance has changed. And therefore you need to be aware, so you've got to give them further appointments. And you're going to have good days and bad days. And the trouble with the modern NHS is that there's such a colossal pressure on eye clinics that saying to someone, oh, we'll have to book you in, I mean, if you don't turn up, you get thrown out. They've had to come back another time and have another decision. It's very cumbersome and difficult for the managers to organise, giving the full force of the weight of the people who need to be seen. So we go to summarize these. So number 3 is you want to make sure that you can actually get there. So when we do attend, there's a safe and reasonable environment for you to come to see us. And that is the layout of departments. Now, eye departments are a mixed bag. Some are very modern and new, some are lesser. And some are specifically designed for the vision impairment, some are less so, who've been sort of have vision impairment cues put in to that. People who've got sight loss and dementia are not as mobile. They're just going to take longer to get around. They're going to have some of them have big wheelchairs. Some of them obviously they come with carers. There's 2 of them, so you've got to look at the number of people. If you've got 50 people coming into your clinic, you need to have chairs for 75 to 100, not just 50 people because they're all going to come with their carers. It's little things like that to provide an environment. I mean, who's been to an eye clinic where it's been standing room only and not able to get a chair? We've all been to one of them. That's because the maximum number of patients you can get through does not equate to the number of chairs you've got, particularly in the chairs. Dementia patients have, as we've seen, beautifully illustrated by Keir in those last videos, there's problems with processing the visual clues that they get around them. So you need to make sure that dementia-friendly environments are provided, particularly got visual impairment. So you've got thousands and thousands of pictures all around the walls, booming sound coming in, there's no baffling, the chairs are all the same colour, the doors are not high contrast. It's very difficult to navigate around. We just built a new eye department where I work, and one of the things I really wanted to get done and got knocked back by the designers was that you go and see the doctor, you see the nurse, and say you can go to the doctor, and they say he's in room number 4. And room number 4 has got a tiny little form tucked away in the middle of it. What you want is you want all the doors painted a different colour. So your doctor is in the blue door, like placement, and your doctor, you need to go behind the green door to get your scan done. That's so much easier for people to do. Unfortunately, I couldn't get this different colour door, but I'm going to one down the go and paint one eye. The other thing as well is that people with dementia, because they're fluctuating levels of cognition, their difficulty comprehending what's going on, will often get confused by crowds. They can function within their home. You take them out of their familiar environment, particularly if they've got sight impairment, they can't function as well outside of that environment. And then you put them in a busy eye clinic where there's 1,000 people running around and it's an early bird event. They can find that very disorientating and it will affect their level of performance. So just to show, this is our new department we just built. This is our main waiting area, which is pretty good. I'm pretty impressed with it. The doors have got these silly little signs which I don't like, and they're the same colours, but apart from that, it's pretty much as I wanted it. You see it's got high contrast chairs, it's got good even lighting, there's some natural light coming in here, you've got these the doors are nicely contrasted, you've got good grab rails, we've got a few pictures up. I want to have some pictures, but we haven't got too many because they can cause disorientation. But this is going to have 50, 60, 70 people in it when it's at full blast. And that can be quite intimidating for the dementia patients. So we have another area which is obviously a lot more quiet, a lot quieter. Not as many people, not much down there. A lot of the quality standards we produce, it came out of what we do for learning disability patients. And it's very similar, really, in many respects. So this is a quieter area. Again, you've got the contrast and the lighting, some natural light and evil lighting, but it's just a quiet area where they can sit. So you can sit down there with their carers, waiting for their appointment. And the other thing as well is that they're not going to last for 2 hours waiting for everything to happen in a clinic, because they're just going to, you're going to get, with all the best will in the world, you're going to get so much time out of them, and then they're going to struggle. So you need to make sure that 2 things happen. One of which is that they don't wait so long in the eye department. So you identify when they come in and they don't wait for 2 or 3 hours. No one likes queue jumping, but there are certain times when you have to just prioritise certain people over others. And the other thing is, as was illustrated beautifully by Martin in the PROVIDE study, is that it takes a lot longer to do a standard assessment on someone with dementia or sight loss than it would with someone else who hasn't. And if you go to the opticians, they can crack through a glasses test in opticians on the high street chains in 20 minutes. They would take an hour to do the domiciliary visits. So it's going to take a lot longer. You have to accept that. So we need to identify these patients when they come into the clinic. The doctor and the nurse is going to have a lot of patients to get through, and work to make sure the patients who come through have a shorter waiting time, and then when they are in the doctors, they're just going to take that bit longer. And you need to understand, if you've got 10 of them come through in the morning, you're going to be pushed to get through them all. If you've got 2 or 3 and half a dozen others, it's going to be a bit more easy to do. And one of the problems with that is identifying. The trouble with dementia is it's a definite ICD-9 diagnosis. It is what it is, and you get diagnosed with dementia. But it's often quite nebulous, and a lot of the carers will come in and say, "Oh, it's got that," and they won't want to say it because it's not a diagnosis that's very common, or that they want to talk to. They want to talk about in front of the patient. So it's often quite difficult to identify these people who have actually got Alzheimer's or dementia, because it's not brought up to us. But what we like to do is get that flagged up to us. And there's various ways of doing that. First of all, make sure our receptionists and our clinic staff flag it up. So they're looking for it and asking for it. They're checking through notes and they're looking for patients and asking patients, right, this is a dementia patient. They've got to go through a separate type of pathway. The other thing that is very helpful to us is if the GP or the Optom can mention that in the letter. And one of the targets we'd like to get is that you get a sort of like a red flag. You don't want to label people too much. There's something to say, this is a dementia patient when they're coming to the hospital, so they didn't know about it. So we're asking the GPs to make sure that they give us some heads up in advance of what that is. The trouble with this is that it gets a little bit difficult with consent and transferring information. So you need to make sure that the GPs and the carers have adequately taken consent from patients to share this information. Even though it is within the healthcare sort of ecosystem of the NHS, you need to have this consent. And also the GPs need to have the capacity and understanding to take this consent and make sure it's okay to disseminate that information. The other thing we can do as well is that when everybody gets sent a letter, and when you think about it, that's a pretty daft thing to do for people with vision impairment, but that's what happens in the NHS. But they get sent a letter saying, please come to the hospital. And what we like to do as well is have in those letters that are sent to the patients, or the way we contact the patients, and we've done on Facebook in 10 years' time, but the way we contact the patients in future has some way of flagging up, tell us if you have a memory problem or dementia, and then we can know about this as well. It's helpful for the patients to tell us as well. So we're looking at it so the GPs can tell us, the patients can tell us, and then we can identify them at reception when they come in so that we know what we're doing. And then once we've got this, a way of keeping this, because it's all well and good that the patient first comes in, but if they have 10 appointments to get their injections or whatever else, you'll know about it for the first one, but you need to know about it continuously for the other appointments they have when they come and say, no, this is Mrs. Jones, she has dementia, because there are hundreds of women to see, this is the one we have to sort out with their dementia pathway. Again, we need to have accessible information. Not about their dementia, but about their vision and eye health. So you've got a cataract, or you've got macular degeneration, or you've got diabetes. That information needs to be provided for you in a way that you can understand. And that happens anyway with all eye diseases. We're very good now at giving people written information. It's been shown to have such an enormous improvement on people's understanding of what's happening and their engagement with their problem. So we need to make sure that the patient information leaflets are in easy to read formats and in a language they can understand. It's braille or large print or electronic or audio versions as well. And most places now will have a facility for doing this. The RNIB are very good at providing these for departments. Lots of other places will be able to provide this for you. So there's this lovely one. RNIB Scotland can't be here, unfortunately. They won't give us a talk. But there is a, I don't know if you've seen it at the back, but it'll be on the slides coming out on the website, so don't worry. There's a booklet called Dementia Sightless by RNIB Scotland, which is very useful resource. It's good. Now, we've heard from the PROVIDE study that it's not as easy to perform a refraction and to assess people's vision. And you've seen from Keir's lovely videos about how people can't walk across the room. When you've got that kind of visual cognitive deficit in someone, sitting in front of a Snellen chart and expecting to read down the chart can be quite a challenge, and you may not necessarily get an assessment of what their vision is. So when people can't do that for whatever reason, then you want to do a thing called a functional vision assessment, which is essentially documenting someone's vision but without using a Snellen chart. So you're looking at things like recording in the notes at this stage in July 2016, Sarah can read the paper. She can find the food on the plate. She can walk around her own home, and she has okay with different light levels. And she knows which pair of glasses to wear. I think we know what to add on to that. If you can do all that, that's a fantastic statement of someone's visual performance. And then when they come back in a year's time or 6 months' time, and you can say, well, they're now not doing all this. Is it because their dementia's got worse, or is it because their sight or their cataract's got worse, or they're not? We've now got macular degeneration in both of those. So this sort of thing is extremely useful as a way of doing it. So if you can't get someone to read down the standard chart for whatever reason, recording this sort of data is incredibly useful as a line in the sand as to what they can do now for future reference. And then the final thing is that when the NHS is, for God love it, for all its beauty, does tend to have a somewhat of a silo type behaviour pattern. And you get into the eye clinic, you get into the memory clinic, and they don't tend to talk to each other very much. And what you need to do is signpost people into lots of different places within the healthcare economy, in an ecosystem, so that they can access as much as possible. And you need to have pathways. We've got very strong pathways for stroke. So when it comes to stroke, we get them into the stroke clinic because they've got eye problems, bang, they're in there within 24 hours. Someone's got cancer, 2 weeks rule, you're in for cancer. What you need to have as well is pathways from your eye clinic into the cognitive sort of fields, things like the memory clinic, or making sure you're getting signposted for severe vision impairment, things like that. So having local support services via agreed pathways at point. And one of the most, so the thing about this is that they're elderly and they've got complex needs, as we all know. So these are things, you've got the low vision clinic, you've got your vision rehabilitation services, particularly through the fourth sector, so a lot of fantastic charities all around the country doing all sorts of things, and memory clinic. And each individual area of the country will have its own particular specialisms in that area. So we've got Surrey Vision in Surrey, which is great. And also getting in contact with memory clinics. There's not great cross-talk between eye clinics and memory clinics at the moment. So hopefully this will start to improve with a bit of nudging. And doing a certificate of vision impairment is a very good way of just triggering this whole pathway. So you may say, well, okay, their vision is whatever on the standard chart, but because of their cognitive impairment, they're obviously going to be partially sighted or fully visually impaired because of the two factors that they can sign the form, and that's going to start to trigger off this process. And one of the main keys to this is the echo. Is there an echo in the room? You got any echoes? Yeah, I love echoes, they're the best. And every eye department should have at least one echo, if not more than one to cover holidays. They're vital.
Sorry, what's an echo?
Sorry, echo is called an eye clinic liaison officer. So they are usually funded by either the CCGs or charities in the area, and their role is to signpost people into different parts of the healthcare ecosystem, and just to sort of provide support. Eye clinics are busy. You know, it used to be the nurses 20 years ago would provide this support, but they're just running around like lunatics with their hair on fire doing all the other stuff now. And what the echoes do is they're fantastic at sitting there and saying, look, you've got this, here's some information about it, let's get you to see this person about that afterwards. So echoes are, there's one take-home message in an eye clinic, get an echo. Thank you.